So here I am again with you today, Day. It's been just about a month since we spoke last. I hope you're doing all right and you getting along okay? You starting to see some light at the end of the tunnel, or are you afraid it's a train coming the other direction?
Yeah, really. Well, the fires have left us and we are having some beautiful fall weather, and we are in a no haze, which for us with all the fires was most of our summer. So it's
Yeah,
nice to see sunshine.
it looks like it's a beautiful day there. So yeah, this is our fireside chat with Day. So she has her fireplace in the background.
Thank you very
And
much. There it is. There it is,
and
fireplace.
and we're also trying to spread a little joy today to our providers. Show them
Wait,
the shirt.
wait. There's my joy shirt. There's my
Yep,
joy
spreading
shirt.
a little joy
There we go. There we go.
to all of our provider friends. So yeah, so we decided to reconnect today just again to talk about some of the ongoing issues that our industry is facing, and I always love getting your perspective. So yeah, let's talk about a few things. So tell us about some of the concerns that you have and see with people losing their jobs and their insurance. What can we do as industry experts to help them out and be a resource for them?
One of the joys we get to be is to be able to be that navigator for our patients. With the Affordable Care Act first came out 10 years ago, there was a paid navigator program that has since expired. But that doesn't mean that we can't help our patients navigate whatever is available in your community or your state. First of all, there is the exchanges. And with the Affordable Care Act, there's something called special services. And when a person loses their job, you don't have to be in open enrollment. You can go into the marketplace, the exchange, which is a web page. Every state has one, and it's very easy to navigate. You put in your address, your income, and then it lets you know what might be available. And with the tax subsidies, then their premium could be reduced, which is a way for us to help our neighbors as taxpayers. We subsidize, and so the insurance companies still get somewhat of their full premium, but the patient gets some help with those premiums. And then when they get their job back and they're able to, which we hope will be soon, they stop that insurance and go back to their commercial market, their commercial employed insurance. Now, for the states that expanded Medicaid, again, only available with the Affordable Care Act, then they could possibly be eligible for that program. So and if you go on your web page and look at Marketplace or Exchange, your state, it has people who have, like in my community, it's Family Health Services, which is a federal clinic. They help, and I can refer people to them and they can help. But I would love to refer to my local hospitals and say, just go talk to their business office. They can help you get online, because the bottom line is if they don't get help, they won't have insurance, they won't pay their bill. They're already devastated for loss of a job. Now they're further devastated because they have no medical help. And we know it's there. Those of us in the rev cycle, we know it's there. We just have to say, now, how can I help my community through this very difficult time of losing their jobs?
Point them in the right direction. And the more people in your organization that know how to direct them to that, the better, as opposed to just a handful being familiar
absolutely.
with that resource.
Yeah, I think it's one of those things that when we talk about, and I love to teach this, I have the privilege to do this, when we talk about our mission, a lot of us in the revenue cycle, our CFOs say things like, cash is king, without margin, there's no mission. Yeah. How about we just switch that? Because when you become a navigator for your community, you then you're living your mission, which should lead to margin. There was a statement that was said to me early in my career, and I've never forgotten it, and it says, I care about the cost of my healthcare, not the cost of healthcare. When we make this personal, and we as revenue cycle leaders train our staff how to be that navigator, to help them with the exchanges, to help them with the Medicaid expanded program, don't just send them to some web page. They're not going to do it. They're scared, they're sick. And remember, all of our medical bills are unsecured loans. So you're not going to go and repossess something to get paid. So our goal is to live our mission, and our margin will follow. And I think that if we take that on, then there's really nothing we can't do to help our patient. Yeah. And by helping them get coverage, either Medicaid expanded, which not every state has, but every state does have the healthcare marketplace or the exchange, if we can get them hooked up that way, then everybody wins. And that's probably the gift of the Affordable Care Act that is just probably not as well known as it should be.
Great advice. Great advice. What else are you seeing that the revenue cycle teams out there should be watching for? I know you and I've talked a little bit about United Healthcare and the objection or the complaint that's been voiced by the AHA, as well as other hospital associations and provider organizations regarding their lab test requirements. We had a payer forum here in Georgia last week, and that issue with United Healthcare came up. And of course, the representatives on the phone with us were happy to listen and pass that information along, but there really wasn't anything that they could do or said they could do on the local level. Talk about that a little bit, but then anything else that revenue cycle leaders should be looking for or looking out for right now.
Yeah, we lovingly refer to this as payers gone wild. United has gone wild, I'm telling you. But United is also the largest commercial plan. So when you think about the power they yield, when you try to think about power, it's like who has the money? That's United. So they are kind of yielding that a little bit recklessly, and they're the ruling they made, their policy I should say, was that every contracted lab with outpatient, that they have to submit all of their lab codes to United for United to issue them their very own code. So United is saying, well, we already have CPT codes. What do you need your unique code for? That's what the big issue is. Why do you need it? But then the second issue is it's in violation of the HIPAA standard transactions. And the HIPAA standard transactions of 2003 said that every covered entity, that's payers and providers, have to abide by the correct coding, ICD and CPT. They do not get to create their own codes. So United has done this pretty much in your face, and the industry is left going, what are you doing? But they have got a January 1st go live. And if you haven't got your charge master set up, your UB, your electronic claim submission, you'll be denied. So I think the American Hospital Association, I really applaud them. There's a group of us that have been working and talking. There's many hospital associations who have written letters. I know that HFMA was asked, National was asked to get involved. The cost, the actual cost to do this is different. We have a Cerner hospital who said they were told it was an estimate of $20,000 to bring this live. And then all the labor cost and all the changes.
It's an administrative burden.
Oh, and why? I mean, that's the one that makes us crazy is the why. We also have site of service bill, which is very significant. I just finished a Zoom training and asked a bunch of Ohio hospitals, and 50% of them have seen site of service referrals. Now, what that really means, I'll just make it personal. My husband had to have an MRI of his shoulder. And so the doctor says, I'm gonna have to ask for prior authorization. So I said, I wanna go to the local hospital. So ask for prior authorization to have my MRI at the local hospital. And my insurance company approved it, but they approved it to a freestanding imaging center about an hour away. And so I said, no, that's not where I wanna go. And the answer was, well, we're sending you to the lowest charge facility because they save money. Of course, they said I would too, but let's not pretend we don't know who saved money. But then they said, well, what if I go to my own hospital? Then I would have had to pay the difference between the two approved amounts. So whatever was approved at the hospital for the MRI, I would pay the difference. So $800, $900, I would pay $100 plus my deductible. The side of service is huge. And I think my advice to every CFO, every CFO out there is to immediately look at your pricing. It's one thing to say, you know, we have to run a hospital, so my MRI of a shoulder is priced higher, but you know, it's my cost again. And when we realize that, you're going to lose what is referred to as your frontline revenue.
Right.
It's being referred away from you because you're the high cost provider.
Gotcha. Gotcha.
Yeah, about the transparency piece of legislation that is being heard right now with the judges, even as we speak. The American Hospital Association is arguing that the transparency piece of legislation that says that we have to make available our gross charges, our negotiated rates, minimum, maximum, there will be no secrets on rates. Yeah. And it doesn't sound like it's going to be overturned. It sounds like January 1st is going to be a go live for transparency.
So let me ask you about that. This is just a little bit off script from what we were going to talk about, but is how what's been your experience? Are hospitals properly prepared? Are hospitals properly prepared for price transparency and the requirements?
We did that last week. I did a couple webinars, Region 2 HFMA in New Jersey, HFMA, and we asked the same question, are you ready for transparency? And the mass majority said they didn't even know if they were. It's like, it's the next thing that we're trying to deal with in the middle of a pandemic, in the middle of all this insurance loss, in the middle of all of this, and this is such a huge undertaking to get this done. And there is a debate. Remember, it's at the courts right now. I think people are hoping that maybe it won't happen, but they did not come in strong at all in either one of those. Maybe 20% said they were ready, but if you ask them what ready means,
Yeah.
Are they really ready to post all that in a machine readable format that anybody can get their hands on?
Right.
There will be no secrets with anything.
Who within the organizations are taking responsibility for making sure that is it the IT department? Is it,
well, it's going to have to be the revenue cycle and the IT, because when a patient calls and says, how do I find out my charges? We have to direct them to a place, probably on your webpage, but the IT folks have got to hear from the revenue cycle, because we're the ones who talk to the patients.
Yeah.
They don't. So what machine readable means is IT language, but what it means to me is the patient can understand it. So we don't want to be the one who makes it so complex that, yeah, we abided by the law, but nobody can find it, and your business office gets complaints and the news media gets all, I mean, come on.
Yeah.
If we're mandated to do it, then we need to do it right. But it also gives us a chance to rewrite narratives so patients understand them, that we understand that your competition down the road, your Blue Cross fees will now be known to them and you will know theirs. I mean, that's what this means.
Yeah.
And it isn't just the patients, it's your competitors. Everybody will see everything. Now, I mean, you can have your own opinion, like what other industry has to release all of their negotiated rates. But this is not a real friendly environment we're in right now, and that's a tough one. And I don't see it. I mean, I was reading the testimony yesterday. It did not sound promising that the judges were going to rule in favor of the healthcare industry.
Yeah,
They might surprise us, but yesterday didn't sound good.
I imagine it's going to have a much wider and much broader impact than anybody anticipates right now. I've heard some companies or some organizations working closely with a business partner, perhaps, to make sure that this is in place and that they've met the expectations. I've actually heard, rumors of other organizations who are willing to pay the penalty instead of putting this in place, which is quite interesting. But
well, and the penalty, if you realize that you go head to head with another hospital and they're going to see your entire rate structure, which is already they've already had to do that. But now they're going to know what Blue Cross, what contracts you have, what are your rates, what are your carve outs. I mean, this is like a very big business. This is not, healthcare is a business, and this is a direct hit into the business strategies. And I'm not sure, I think, let me tell you, Bill, if some of the other stuff wasn't working against us, like surprise bills, if that of the hospital in-network, and they have their rad docs, their ER docs, their pathologists, which are the big ones, who are not in the network, and there's massive pushback from our public about a surprise bill that the patient pays out of network penalties, everybody and their dog hates us for that. I mean, pick somebody. You mentioned it, the hospital's gouging. I mean, that's what they feel like. It's my healthcare. So with all that going on, and now we're back going, well, we shouldn't have to tell everybody everything. They're like, oh, sure, you can't, you don't know how to run a business. And so I think the backlash is what's happening right now with transparency. That's my gut feel.
Yeah, it always reminds me of the analogy, I love to do yard work and I love to cut the grass. And it's kind of like if I were doing that for a living and someone hired me and said, you need to cut my grass, but you need to do it with one arm tied behind your back and you need to do it with a pair of scissors. It just seems like.
And you better not charge more than the guy who does it with all the fancy tools either. You better charge the same. Yeah. Even though it took you 3 hours and took him 30 minutes.
That's right.
It's the same sort of thing. Yeah, for sure.
It's a lot more complicated than we need to make it. So let me ask you another question if I can. You had brought up with me the issue of short-term insurance and how it changes the way coverage research is done. I wasn't as familiar with that. What does the insured really have, since it doesn't cover the 10 essential benefits of the ACA? Talk about that a little bit.
Yeah, this is kind of deadly. with the, there was an executive order signed recently that about a year ago that said if there was, remember the 10 essential, protection with pre-existing 26-year-olds, no cap on benefits, the program that's been around for every insurance plan for 10 years, what happened was the executive order said that if one plan with all that protection was on the exchange, then the state could sell short-term plans that were supposed to be up to 3 years. But these plans could say no pre-existing, no cap on benefits, pick your prescription, like the cafeteria plans, but
Yeah.
man, were they narrow in focus. So patients who saw a big drop in premiums went, sign me up for the short term because their premiums dropped so much, but guess what happened to their coverage?
Mm-hmm.
So I think what's happening too for us in the healthcare world when we're prior authorizing and validating benefits, I should say validating benefits, we go out and we're looking for we've seen the same thing for 10 years. So you don't know to look to see if it's a short-term health plan that has much limited coverage, like 1 ER visit a year, no prescription drugs. I mean, you pick what you want, and in return, you have this really tiny premium, but your package is. So our prior auth folks, our benefit validation folks, don't understand that when they're validating, they have to look to see if it's a short-term health plan, and then see that very reduced coverage that this patient has, which they probably have no idea how limited their coverage is.
Gotcha. Interesting. Okay. Anything else?
By the way, I was offered that. I was offered a short-term plan when, as a small employer, I went looking for cheaper insurance, and I was offered one this year for the first time. Yeah.
Well, I feel bad because
it was a lower premium.
Yeah. As a small employer, you're not given a whole lot of options, and
no, we aren't.
But
we're given very few options, and they're very expensive. So, you know, a small employer, I'd be looking for this plan and say, I'll keep it for 3 years. And then in 3 years, who knows what health care will look like. But I wouldn't have had a very good understanding of my limited coverage.
Right.
People just don't.
We'll see. Anything else that you'd like for folks to think about or pay attention to right now that might help them in their day-to-day work and interaction with patients and payers? Are there any specific topics that maybe we missed?
Probably the payers, the managed Medicares. Out on my website, I've just updated the class on Medicare Advantages, taking your power back. And we really do have a very nice guide on addendums to contracts that are very operation-based, like peer-to-peer calls, sending records, not sending records, timeline for turnarounds, all those operational things that we don't usually get into a contract, because contracts usually have rates. So we've included that. We also helped people know that their Medicare Managed Care Manual has a section in it that does not allow a Medicare Advantage plan after they have authorized inpatient to come back later, a year, 2 years, hire a company to come back and take away your inpatient after they have prior authorized it. There's actually pieces within the Medicare Advantage and this right in the class, go get it, take your power back, and just send that letter to the payer going, nope, you don't get to do this. You're in violation of the Medicare Managed Care Manual. So it's a great power taker backer because we're getting killed with those.
Yeah.
But I always kind of remind hospitals, when you send that letter, put your attorney's name on it. You know, you're in violation of this reg. If you don't, cease and desist, we'll file a complaint with traditional Medicare who oversees Medicare Advantage, and attorneys sign it. I think it gets more attention than just a revenue cycle person who they go, you don't know what you're talking about. Well, it's a powerful piece. Yeah. Those two are big ones.
Yeah, like anything else, if those follow-up reps are showing that they are knowledgeable about some of those regulations and those restrictions, then and they can speak to those, you know, they're less likely to be taken advantage of when they're having those interactions. Now that reminds me of one of the things that was pretty consistent last week in our payer forum. From all payers, we had a different payer speak each day during the week, was they, again, are continuing to encourage providers to go to their website, go to their portals, their provider portals, right, and do as much as they can. They don't have it all worked out and running, you know, super smooth just yet, but that was the what I heard as a kind of common denominator was make sure that you're accessing the resources that are available to you on those individual payer sites. Now, there were things that were brought up about, how one group within the organization communicates with the other group and some concerns and around some of that, but maybe we'll get there. But that was the other thing, the old traditional dial up the call center, get on hold and ask about a claim and then follow up on that was not encouraged. And just to really double down, make sure you're documenting well, and don't hesitate to escalate a situation to other people that can help get those issues resolved. So I thought that was pretty
Yeah, I would think that we have to pick up a phone when we have a pattern of abuse, or we have to pick up a phone when you've requested records again, for what reason, you're in violation of our contract. Request for records needs to be contracted.
Yeah.
And those are the kind of things that the portal won't help. Researching of a claim, yeah. But if the claim didn't pay right, we have to talk to somebody. And that's hard because they too have cut down their human capital just like hospitals have.
Sure.
We are computer crazy and not remembering that these are patients who didn't ask to get sick, who didn't ask to have their life disrupted, didn't ask to have their insurance pay so little.
That's
and
right.
And from an insurance perspective, they're trying to cut costs too, go to our portal. Hospitals say, go to our portal.
Right.
And the patient's in the middle going, I have no idea what any of you just said.
Right.
So
I want to make sure
we still have to navigate.
I want to make sure we didn't overlook anything related to Medicare regulations as we get into 2021. Was there anything additional related to that folks need to know, or will you maybe have some of that in your info line? I know you mentioned it in your August info line.
Yeah, we are. The transparency is big. That will take effect January of 21 if it doesn't get delayed by the court hearings that's going on right now. We have the more of the inpatient onlys coming off. That's going to be a big hit because spinal fusion is now no longer going to be considered inpatient. You have to earn the inpatient with the 2-midnight rule and the very distinct documentation. I think the loss of inpatient only is going to be such a financial hit. And we will, and as CMS has said, they plan to roll it out over the next 3 years. That's going to be big, and people have got to do their financial analysis of if you lose all these inpatients, 20% go outpatient. What kind of financial hit are you going to get out of your traditional market? And remember, the Medicare Advantage plans state that they have used the Medicare only list in some of their decisions. So now what are they going to use to determine an inpatient surgery? Sure. I would think 2021, we better get real busy at doing good business practices and doing an analysis of our inpatient onlys with the traditional Medicare market, and probably Medicare Advantage, because they'll use the opportunity not to approve inpatients as well. That's big. It may not happen right now, but it will be happening.
Sure. They keep us on our toes, I'll tell you. Just
did you want me to share something cheery?
Yeah.
I said, did you? No, nothing. Just throw
it out. When you find it,
I thought you would enjoy that.
Let me know. When you find it, let me know.
I'll put it in the info line. I'll put it in the info line.
We'll do a special call just to talk about that.
Just for cheery. I'm ready for cheery.
Yeah, most definitely. From my perspective in the business, we are starting to see the activity pick up. A lot of hospitals say that they feel like their volumes are rebounding. But, we're also seeing, I think as of today, 221,000 COVID deaths and, more cases all the time. I mean, some states have had some record days still. So we may be seeing another wave of this. I certainly hope not. We've got the election that's going to figure into all this. You have people that say it's all going to go away after the election. So, this is not a political forum for you and I, but we know that there's a lot of stuff going on, a lot of moving parts. And, we'll react and respond and be resilient, just like we always have. You've been in this business a lot of years, and I've been in this business a little while now too. And every year it seems there's a new challenge, and we always figure out a way to get through it. And I've seen that there's some tremendously strong and dedicated and committed healthcare professionals in our industry, not just on the clinical side, but as you know, on the revenue cycle and financial side. And these organizations,
I think our revenue cycles are just another kind of hero, Bill.
They really are.
We have a hero, and by being a navigator, we have become a hero. They are the caregivers, and then there's us, and we are the other group of heroes who try to help our patients navigate such difficult times.
They are.
And I'm with you, Bill. The COVID outbreak in Idaho, I'll just give you my state. Our hospitals put out a call that they're full. Where our hospitals are full, we had 1,000 new cases in a little population of not even 2 million. And we're up in our numbers are off the map. Our positivity rate, 20. It's hard to watch, and I'm tired of it too. I mean, I would love to be able to go hug everybody I see again. I'm a hugger, you know. But on the other hand, I'm going to wear my mask. I'm going to keep my family. We have multiple, my granddaughters in RN. She's just coming off of having COVID. Her husband got it so we have all kinds of real live issues hitting our family. And then you just kind of step back and go, we've got to take care of each other. So I'm all about, I would love to be having this conversation with you the first quarter of 2021 and say, do you remember what it was like last year?
Wow.
And be able to have a cheery conversation then. Because right now we're just holding on by our fingernails.
Yeah, we really are doing the best we can, but it's we've made it this far with a lot of really great people who've done their part to make it happen. So I hope that will continue. So you have your info line coming out next week. Folks can look for that. I will include in this, when I post this recording, I'll include your contact information, and folks can go on your website and sign up for that if they aren't already. But I know the ones that get it feel like it always contains a lot of really valuable information.
Well, thank you. And also remember, when you get the web page, all those classes are out there. The foundation, the Patient Financial Navigator Foundation, has all of the Medicare outreach that we do. And then the AR Systems has all those other classes we teach that I kind of talk about sometimes. None of them are copyrighted. Please just take them and use them. Yeah. I also write articles, Healthcare Buzz, on the foundation's webpage. I wrote a 4-part series on how to use the exchange. So it's so easy, but people just don't know it. Go get it, take it, put your name on it. I don't care, because it's more important that we are a healthcare family, a village, and as we help each other, I want to share that with you. So go get it, use it, and just make your community will love you. They so need us to help them.
That's wonderful. That's wonderful. It's always good to talk to you. You're a great person, and I appreciate you so much, and I know other people do too. And I hope that we'll get a chance to have another conversation. Like you said, maybe sometime during the holidays, we could bring a little Christmas cheer. We'll wear some Santa hats or something. And
well, way better, because I'll be feeling down in the dumps because my family doesn't get to come and be with me for the first time ever. Yeah. So I'm sure you're feeling the same way, Bill, because you are a special person as well. Yeah, so
a little bit, but
it's hard.
We'll figure it out. This too shall pass. It might be like a kidney stone, but this too shall pass.
I keep saying, if we take care of each other, we will look at 2021. Let's just take care of each other now.
Yeah. It can't get here fast enough, but I am trying to cherish the moments that we do have, and I am very grateful. And I know my blessings are abundant, and I know you feel the same way. And we got to keep pushing forward. The saying I had last week that I thought was appropriate was, life is like riding a bicycle. In order to keep balance, you just have to keep moving. And
great idea. That's beautiful. I tell you, I know Bill, I've known you forever. You're a jewel, and you're such an HFMA person. We call you Mr. HFMA in case you didn't know that, behind your back, but to your face. Yeah. And I just think it's one of those things that I always talk about HFMA's village. Mm-hmm. This is an example of a village where we just say, why don't we get together and talk and see if we can help somebody else. All the virtual education we're doing. I'll just share this as a last thought. I just finished some great sessions, and they had like 500 people. Now, I've been to their conferences, and I said that to them. And I said, you've never had 500 people in your room ever. And they said, we're getting people who never, ever get to travel. And I said, now there's your blessing. And maybe we look at hybrid in the future. Right. And maybe we look at saying, how do we reach the person who doesn't get to travel? They can get the education this way. Because we've all discovered we can do it. Sure. And I was so pleased to say to them, this is your silver lining. That's because great. Now we're touching those frontline employees who would never get to travel for their education, and the mid-levels, and they're all, I had one room and they said they had 6 people in the room where they got to listen to the whole day. And I thought, wow, when does that ever happen? So there are blessings. There are so many blessings that we have, and I'm tickled to be able to talk about them because I feel the same way. I get to listen to things that I wouldn't be able to participate in if I had
That's
to
right.
travel to it. So
That's right.
I'm a taker too. I'm a student.
I'll get you that link for the Georgia Fall Conference.
Okay, that'd be great.
Fall
Thank you.
Conference. But yeah, always good to talk to you. Thanks so much. Stay well.
Absolutely. You as well. Bye, everybody.
Talk
Bye,
again
Mr.
soon.
Bill.
Show them your shirt again.
Thanks.
Show
Oh
'em
yeah,
your shirt.
Joy. Wait,
Spread
this
a
is
little
the
joy.
all-time best shirt.
Spread a little joy.
Joy. Thank you. Bye, everybody. Bye, Bill.